We have some highly esteemed medical professionals from the Pittsburgh area. I'll introduce them in a moment. And then we'll start with the questions that were submitted ahead of time, and then we're going to open it up for questions. And we have an hour to do so, and then we'll finish up. I'll start on the other side. We have Dr. Priya Cardone. She's a movement disorder specialist neurologist from UPMC. And then we have Dr. Matthew Woodward, who's a movement disorder specialist from Allegheny Health Network. And then we have Dr. Valerie Suski, who's a movement disorder specialist neurologist from UPMC. And then we have Dr. Nikita Urval
Yeah.
from Butler Independence Health System. So heading up north a little bit. We have Kaci Monhart, nurse practitioner, Allegheny Health Network. She focuses on movement disorders. We have Dr. Timothy Leichliter, movement disorder specialist, Allegheny Health Network. And lastly, Jessica Neiss, who is an amazing physical therapist that specializes in Parkinson's and has 2 Life physical therapy in Squirrel Hill area. Okay, so I have some questions that we're going to ask ahead of time, and then we'll open it up. Okay, Dr. Woodward, do you have any wisdom about the most effective way to treat depression in Parkinson's?
Ooh, it's a good question, and I think probably a lot of us, for a lot of these questions, will also caveat with that you should talk with your movement specialist or your neurologist or your primary care psychiatrist, as a lot of these things take a team. So, in terms of the things outside of discussing with your health team, I think one of the biggest things is just being active, both, from a cognitive standpoint as well as a physical standpoint. So the more you move, a body in motion stays in motion, a body at rest stays at rest. So the more you're up and active and stimulating your body and your brain, the more that's going to kind of pay off for you. Depression itself is really tough and something that you have to actively push back against. Both yourself and those around you have to kind of help you with that, I think. And just trying to not let it win. But at the end of the day, I think, sometimes we do need to use medication, and that's okay. Sometimes we do need you to talk to someone who specializes in mental health, someone who is outside your sphere of influence, who is a kind of impartial person who can discuss issues or involve your family in a conversation together. And so it's maybe a little bit of a cop-out answer, but I think it's pretty individualized for each person. But it could be a combination of exercise, medication, talk therapy, pushing back against it yourself and having others around you really trying to help you with that. And being aware, don't be afraid to say, my mood is low, and how can we work on this together?
Thank you, Dr. Woodward. Go ahead, Dr. Suski.
I agree. Exercise releases these natural endorphins and kind of gives us this natural high, so it can lift our mood. It also depends on why you're depressed. Now, sometimes there's reactive depression, right? So I just told you had Parkinson's and your mood goes down. So that doesn't mean you necessarily have to medicate. It just might be that you just need a little bit of time to wrap your head around this diagnosis. Some people need medications, and there's no one medication that's better than others. There's ones that can kill 2 birds with 1 stone that might help with anxiety and depression, and some that actually might work a little with if you have a little OCD too, and some that might help with sleep. So there's no one medication that's better than the other, but it's really good to get your doctor involved in that. But it's, were you always a depressed person? Is this something that, you had a power outage and now I'm depressed? There's lots of different reasons why depression happens, and it's not one specific thing that we do. We individualize it. Remember, our brains, I always say this over and over again, our brains are like snowflakes. We're very unique, and everybody's treatment should be individualized.
Thank you, Dr. Suski. And Dr. Cardone would like to say something?
Yes, I agree. I'm also quite aggressive about treating anxiety and depression in addition to Parkinson's disease, because one of the major things I observe is if you are depressed, that can actually make your body move slower. It's called psychomotor slowing, and that is separate from the slowing that occurs with Parkinson's disease. So sometimes when I see patients and I feel that their depression symptoms are actually worse than their Parkinson's symptoms, I actually recommend they treat the depression first so that I can remove that element from their physical exam, and then I see them again, and whatever's left over, I can say, okay, that's mostly now really just your Parkinson's symptoms, so that I could treat the Parkinson's separate from the depression, even though it does go together and overlap.
Thank you. We'll move on to the next question, Dr. Leichliter. Do you believe that levodopa carbidopa can be a cause or a cure? You may have been asked this one before.
Yes. I don't think it's either, actually. It's definitely not a cure. I mean, carbidopa, levodopa has never cured anybody of anything. It's a treatment. It's probably one of our better medications that we have. Not as good as exercise, as everybody here knows. But it is a good medication for the people who need it, for when it's warranted, when it's deserved. It's not curing anything. It's not slowing down your disease progression. It's not keeping you better longer. It's not altering the course. It's not correcting the underlying neurodegenerative condition or brain process. It's treating symptoms. I don't think it's causing any problem. Well, I take it back. I don't think it's causing the disease either. It has a host of side effects. I don't have a side effect-free drug. That doesn't exist. Everything that we do, every medication that we have comes with a price. And that price is usually side effects. And carbidopa, levodopa is by no means free of side effects or long-term complications or development of issues as you use more and more of it. I don't think it causes Parkinson's disease, which I've had a conversation about recently. And so I don't think it's actually either of those things. I think it's a useful tool to help people do a little bit better, help have a little bit more active life, a physical movement ability, pretty much no more, no less.
Thank you. Jessica Neiss. I keep losing the question. How do you continue to stay motivated when you have a Parkinson's diagnosis?
That's a hard thing to do. I know that lack of motivation is a big issue, but I think getting involved, one is having all of the right team members, right? So having a physical therapist as part of your team is really, really important. These guys are extra important, but so are we. And so I think it's finding the right person that you feel motivates you to help you keep going. And so that's one-on-one therapy. And then it's also finding your people, finding your group. You know, you guys are here in a big group. There are lots of group exercise classes, which we always call like group support groups, active support groups, right? Exercise classes are like active support groups. They're fun. You're doing things with other people that have Parkinson's. They help motivate, you guys help motivate each other. So I think those things are really important as well.
Thank you. Go ahead, Dr. Leichliter.
And we love our physical therapists. So you need physical therapy, lots of it. Finding a purpose, I find, is really important. If you have a purpose, a goal, something you want to accomplish, something you want to do, something that keeps you going, that tends to help with motivation. And motivation is a really hard thing to come by. But in addition to all the exercise that all of us talk about, which definitely helps, finding a purpose, having something you're living for, having something you're trying to accomplish, a goal, and setting that goal and telling other people that goal really help motivate, keep you going in that direction.
Thank you.
I
Go
can
ahead.
say something too. I have to talk about apathy really fast. So apathy is the lack of motivation. That's very common in Parkinson's. And so it's that get up and go has gone up and went. So I always tell patients, it's not an excuse. Oh, it's my apathy. I'm not going to the gym. You know, you have to have a schedule. Apathy is a very, very problematic thing for a lot of people. And so I say, get your dry erase board that has a calendar and put those dates on there. And then when it's on there, you got to go. And then I say, have a backup. So if you exercise outside, you got to exercise somewhere else, like the mall or something, you know, that has no rain, like today. So it can interfere with our motivation, but it's not an excuse, I say.
Thank you. Moving on, Kaci, Can you please talk about the long-term use of carbidopa, levodopa, and delirium?
Sure. Long-term use of carbidopa levodopa doesn't necessarily contribute. Can you hear me now?
Just talk louder.
Okay, I will just project. So long-term use of carbidopa levodopa doesn't necessarily lead to delirium. Delirium's complex. So you can get some side effects with the long-term use of carbidopa levodopa, but it also comes with a disease. It can also be impacted by other things like infections and illness and other comorbidities. Stress levels, fatigue. There's a whole lot that can go into it that can impact your cognition. So it's more of a complex thing. But, one of the side effects of carbidopa levodopa is hallucination. So it can be contributing. So it's all a balancing act and keeping the lines of communication open. And any drastic changes overnight, it's always important to look for other causes, keep in contact, close contact with your healthcare team to be able to come to the root cause. And if you're having more issues, then to have those conversations so that we can do something about it.
Thank you. And Dr. Urval, what's the best way to manage fatigue from medications? Kind of similar themes.
Yes. Well, it's very tricky because fatigue on its own is a major symptom with Parkinson's. But yes, you can get more fatigued with certain medications, typically because a lot of these medications affecting dopamine can lower your blood pressure a little bit. So that's always one thing to look out for is, does your blood pressure tend to drop, which also your blood pressure tends to go down over time with Parkinson's, and then you can start getting the orthostatic hypotension, where when you go from laying to sitting or sitting to standing, your blood pressure drops. That can make you lightheaded, but that can also contribute to fatigue. So it's a tricky thing to manage. It's trying to get you the right amount of medication without worsening side effects. Sometimes switching from an immediate release version to an extended release can sometimes help soften that a little bit. Sometimes just having a little extra glass of water or something with electrolytes and juice, that can kind of help combat it. And then sometimes, honestly, having some caffeine, that's going to help a little bit too.
Thank you. Go ahead, Dr. Cardone. Thank you, Dr. Urval.
The other issue with fatigue and also apathy is making sure there's no other medical issues that are contributing. So my biggest pet peeve is sleep apnea. If you're one of my patients, I've probably forced you to get a home sleep test. Untreated sleep apnea is very common. It's very common in patients with Parkinson's disease, just more common as you get older. It causes a lot of fatigue, wear and tear on the brain, and makes all of the Parkinson's disease symptoms worse. So making sure that you don't have apnea or something like B12 or iron deficiency, which also contribute to fatigue, is important to make sure that you have as much energy as possible and are not becoming tired from another medical issue.
Thank you, Dr. Cardone. And this question is for Dr. Suski. I have been diagnosed with PD, but I do not have the most common symptoms. My concern is that I do not have any discernible impact from taking levodopa. What other options are available for me?
Good question. So if I'm getting this right. So sometimes people come in and they have, from our standpoint, they meet the criteria for Parkinson's, but like maybe they don't have the tremor, the classic tremor, and it's just stiff and slow. And it's so mild that, if they take the medicines, they're not sure if it's helping or not. Sometimes there are atypical processes that kind of mimic Parkinson's that are a little bit different, but just a cousin to it that may not get as much of a benefit for levodopa as well. Sometimes I will, I definitely push the exercise if you're not doing levodopa, or, you might stay on a little bit because I think that the exam is changing. There are other medications. You just got to be careful that they're right for you, because every medicine has a side effect. So I guess it's trying to find out if that's a better thing for you or not. But I don't know if I'm even answering this question right, if I'm getting. Anybody else want to chime
No,
in
I
there?
agree. I mean, you get a lot of different things. Not everything that comes in looking like Parkinson's disease is necessarily true Parkinson's disease, as Dr. Suski was saying. And everybody's a little bit different. If one medicine doesn't work, we may try other ones. We may not find one that really is all that effective, and we use a lot of exercise, a lot of physical therapy, a lot of movement. As she mentioned, everything's individualized. So when you come to the office, we talk to you about you, your symptoms, your response to medicine, and we figure out what makes the most sense for you.
Thank you. Can you please discuss, let's see, Dr. Urval, can you please discuss the genetic factors that are related to Parkinson's?
Sure. So there's variable. Okay, so there are a couple genes that we have identified that have been linked with Parkinson's, and some of those are for young onset specifically. So a lot of times if someone is under the age of 40, then I'm going to check some of these genetic factors, as that can kind of guide it. And it might even look different than your typical Parkinson's initially. When you're younger, it might be more of a dystonia or something like that. It might look a little bit different. And then there's other factors like GBA or LRRK2, other genes that are associated with it. And I always say if you have one of these mutations, it does not cause you to have Parkinson's. It can increase your risk. Like you might go from 1% to 6% chance of having it. And it tends to run in certain cultural groups. So most of the time, it's not something that I think of as regularly running in families unless maybe you're part of one of those cultural groups. Most of the time, I'm sure there is some genetic component to it that's been hard for us to characterize with a mix of environmental, but as of now, there are studies looking into, looking at if you have a GBA mutation, maybe that's treated a little bit differently. And so a lot of times I'll offer, if you're interested in a study, then I'm happy to test or check the genes. But as of now, it wouldn't necessarily change how I treat you. So,
Thank you. Dr. Suski,
So
and then
I agree.
Dr. Cardone.
In the past, if I had somebody that came in, they're like, my brother had it, my mother had it, if we would try to check those genes, insurance would say no. We're not going to cover it because there's nothing that we do different. I know I've said this to some people. There is a study that's free for everyone. It's called PD Generation. It's through the National Parkinson's Foundation. You do it online. You get like a anonymous number attached to you. They send you out a kit to your home. You do a swab on the cheek. You send it in to their study. They run 7 genes, and they will let you know if one of those 7 genes are positive. And those are the bigger ones. Now, out of those 7 genes, I think there are about 2 or 3 clinical trials that we have out there that are trying to target the problem. So that's a way to get free genetic testing through the National Parkinson's Foundation. What they do with your samples afterwards is they look for biomarkers. Biomarkers are what makes us unique. So, how we are the same, so let's say if I'm comparing myself to like a monkey or a pig or a mouse, we all, when we compare ourselves, we have about 99% of the genes that are similar, but what makes us different are these biomarkers. So we're all alike, but we have very unique qualities, right? If you look at the person next to you, you're not an identical twin to somebody. So they're looking at biomarkers that makes us unique. What makes our Parkinson's alike? And so they take your samples and they compare it with everybody else nationally that are signing up for this, volunteering. I call it volunteering, no one is forced. And they see, is there anything else that we're missing? Is there a gene that we're missing that we need to target medications to? So by you participating in it, like I said, you do get free genetic testing, and they tell you if you're positive or negative. Most people I feel like are negative. But then they're using your samples to see, is there anything else that we're missing? Are there genes that we're missing? Is there medications that would target one person and a group of people that we're missing?
Thank you. Dr. Cardone?
That was the same thing I was going to say.
Okay, wow.
The PD generation.
Good minds think alike. Let's see. Jessica, Neiss, what are some ways, especially, we'll first explore regarding physical therapy, managing orthostatic hypotension.
Orthostatic hypotension is a little bit tricky just because in a lot of people, it's exercise induced. So when we want to push you hard to do a lot of high intensity exercise, that's when the orthostasis happens the most. And so for us in therapy, we try some of the external uses. We recommend compression stockings to wear during exercise. We recommend abdominal binders. And then honestly, if things get difficult, hydration is a really big part of that as well, making sure that you drink enough fluids with a little bit of electrolytes as well. So we try to put people on a drinking plan for water and electrolytes throughout the day. But if all of those things fail, then we refer back to the docs because there are good meds that they can give to help with that as well.
Okay, thank you, Jessica. Dr. Woodward, do you mind commenting on the doctor part of orthostatic
sure.
hypotension?
Yeah, so there are certainly the non-medication options, and physical therapy can help us a lot with that. And I tend to provide a lot in the after-visit paperwork about things that you can do at home that are still non-medication. So staying hydrated, like we said, and even just the act of drinking water, like taking a sip, especially a cold sip of water, stimulates the blood pressure to rise a little bit. So you wake up in the morning, you have a couple sips of water, and then get up from out of bed, you may find that you do a little bit better. If you don't have a cardiac reason for avoiding salt, increasing salt in the diet, compression, not just sometimes stockings, but thigh highs or all the way up to the waist can be helpful, although we certainly recognize they can be tough to get on in a lot of cases, at least the ones that really provide the adequate pressure to bring that fluid back up into the system. And then sometimes, even despite all those best efforts and making sure you change position slowly and you squeeze big muscles to kind of keep blood flowing and moving along, we sometimes will use medications, and fortunately there are quite a few options out there. I will just say that I run into this a lot of people that may be started on a specific one called Midodrine, and they're told to take it 3 times a day, and a lot of my patients will tell me that they take that last dose right as they go to bed. And with these medications and with Parkinson's, it's raising your blood pressure, and Parkinson's, not only can you get this orthostatic hypotension, you stand and it drops, but you can get something called supine hypertension. When you lay down, it can go high. And sometimes, if it's 160 over something, 10, 20 years from now, that's a worry. But if you're going up to, and this can happen, 200 or something over something high, that can be more quickly dangerous. And so Midodrine can sometimes, and some of these other blood pressure medications we use can sometimes worsen that. So you just want to make sure that you're really sticking to daytime hours when you're using these medications to give you the best benefit and also avoid any of these times where you may have an increase in pressure because you're less active or particularly laying flat. So just in general, try to avoid laying flat for 5, 6, maybe more hours after you take some of these medications. But there's Midodrine, there's fludrocortisone or Florinef, droxidopa, which if you ever have trouble getting through insurance, there are some wholesale pharmacies that we can sometimes use, like Blueberry Pharmacy or Cost Plus Drugs, to get it at a much more affordable price. But there's a lot of options out there that we can potentially use and will be individualized to your condition and your other medications and other medical issues.
Thank you. Dr. Suski?
I agree about the bedtime one. I'm always pulling that off at bedtime. But so there's other times during the day that you're more likely to have lower blood pressure. One is in the morning. So especially when you get up first thing in the morning, I tell you to sit on the side of the bed and think about how I don't have power. And then you stand up, and then you still think, well, Dr. Suski still doesn't have power. And then you get moving. The other thing is we all like hot showers. I really like hot showers, but right now I have cold showers because Dr. Suski doesn't have power. Hot showers can lower your blood pressure too. Eating big meals, and I know that everybody is trying to figure out when to take their levodopa and when to time it with their meals. But big meals can drop your pressure too. So you can eat smaller meals and you're just going to have to figure out when to do the timing. Medications, I agree with the medications. Sometimes we get cardiology involved because they come up with these really elaborate, if your blood pressure's this, don't take this, or you take this. So the other thing we need to do is really reassess. You have to tell your doctors that this is happening. When I go from sitting to standing, I feel like I'm passing out. Sometimes it's cardiac. You know, we do have people that say, I pass out, and they're told that, well, this is your Parkinson's, or, you know, and it's their heart. So we do cardiac event monitors and things like that, and that can get missed even by the ER. So, you know, we do orthostatics in the office to double check this, but sometimes it is the heart. Sometimes it's the medicines we are giving you and the timing of the medicines. So maybe a dopamine agonist shouldn't be what you should, like you're on right now, or amantadine. You know, we really have to judge your medicines too. So it's, once again, very individualized. We have to take each person different.
Thank you.
I think also making sure that, you know, it's not uncommon to have high blood pressure, and then as we get older, maybe we don't need quite as much medicine. So always looking at the whole picture and making sure that you're not already on a cardiac medication that's going to lower your blood pressure. Maybe that needs to be reevaluated as well.
I think that kind of goes to what I was saying earlier of, in 10, 15, 20 years, I might be worried about a 160 over 90, but acutely I'm going to be worried about you falling because your pressure lows and you hit your head or break a hip or something. And so let's discuss with your primary care, your cardiologist, if we can find a happy medium. Maybe it's a little higher, but we take that risk because the lows are so dangerous.
Okay, thank you.
Can I just say one more thing about that?
Yes, go ahead, Jessica.
And just from like an education standpoint, so something that you can do, like if you are experiencing orthostatic hypotension, is when you have to change positions. So if, let's say you've been sitting and watching a TV show for a while and you have to get up and go to the bathroom, you know, it may feel like it's an emergency type of a situation that you have to go to the bathroom, but is it better for you to have an accident, or is it better for you to be on the floor? So we always tell people, you know, take your time in changing positions. And if you're going from sitting to standing, you know, take a minute and stand there, you know, march in place, do some heel raises, get your blood pressure in a place where you feel like you can go, instead of just changing position and going immediately. Same thing from laying down. If you're sleeping and then you have to get up to go to the bathroom in the middle of the night, like Dr. Suski said, take a minute, sit on the edge of the bed, do your ankle pumps, do some kicks, get some of those bigger muscle groups to bring the blood back up to your body and your brain, and so then that way you're not going to pass out. So it's worth taking those like minute or so, even though you feel like it's an emergency situation, because orthostasis doesn't always happen immediately. It can happen like a minute or so after you stand up, then you feel like you're going to pass out, and by then it's too late. So take a minute and breathe through it.
And I know that we all don't like to drink water, because what happens after you drink water, you have to go pee. And if you're having a hard time, whether it be festination or freezing or just even getting to the bathroom, we tend to back it down on our own. But, you know, over time, your body will get used to it a little bit, and then, you know, sometimes we'll even offer electrolyte drinks just to kind of expand your blood volume so it doesn't drop as well. But once again, you need to talk about it with your doctor.
I will say another thing that can
Sure.
be good. Oh, sorry. Another thing that can be good is, I always say, because a lot of people also don't like water, just plain water, is it can be other things. Like, I just want something that has fluids in it, and if, depending on your other medical issues, if you can have the salt, something that's fluid and salt, like juices. I mean, I don't know if anyone likes tomato juice or V8. That's going to bring your pressure up pretty quickly. That's like, if you can tolerate it in the morning, that's a lot of times what I'll tell people. If you can have a little bit of V8, that's going to make a pretty big difference to your morning. Salty soups, that kind of thing. So I always say, if you don't like water itself, there are other options, just as long as it's not alcohol or caffeine.
Yes, iced tea doesn't count because that has caffeine, unless it's diet, or not diet, caffeine-free. Soda doesn't count, although it does have sodium, but you know, coffee does not count as your water intake.
I usually say 6 to 8 non-caffeinated beverages per day, and then any caffeinated or alcohol is a -1, so you can keep track of the numbers. And the other thing to kind of go off on this is, yes, if you are someone who is getting to be more sensitive to medications, and lightheadedness and dizziness seems to be associated with as a medication side effect, that would be a good time to start to think about surgical treatment options for Parkinson's disease, which can remove the need and the burden of a lot of the medications, and that would mitigate some of the side effects of medications if you are not as dependent on oral medications, because they can either do a surgical treatment option that provides electrical stimulation, or insert medicine into your body at a place in the gut where it would bypass the part where you get the lightheadedness or dizziness or any other side effects of medications.
Okay, thank you everyone for your input. Dr. Cardone, what is the current state of stem cell treatment for Parkinson's, the legitimacy of commercial organizations, Stem Cell of America, and their success in relieving Parkinson's symptoms?
Okay,
It's a long question.
I might pass this to someone else, but
Sure.
my caveat is like, if it's not FDA approved, I don't spend too much time reading, learning, or anything because it's just not there, and I just focus on the things that I can use to help people. I don't like people getting false hope about stuff. And my rule of thumb is if you have to pay more than $20 for anything out of pocket, please check with me and I will probably tell you that that's not worth it. That's my spiel on that.
That's helpful.
Anybody else has?
So I think where I was doing fellowship, University of Colorado, they were some of the first folks looking into stem cells for a lot of different processes, and it still is a very exciting area of interest. And I think interest is maybe one of the big words here right now, because there's still a lot of hurdles that we need to figure out. You know, if you're using stem cells from other individuals, can you have an actual like inflammatory reaction to the stem cells? You know, can the stem cells be rejected, or can the stem cells reject your body? Both of those things can happen, and those can be dangerous. Can we create stem cells from you know, your blood, from your bone marrow, those sorts of things. And so it's certainly an area of interest. If we're losing these dopamine cells in the brain, can we bring those dopamine cells back? And how do we deliver them? That's also another important mechanism to think about. Can we put it in the blood? Do we have to access your spinal fluid? Do we have to put a needle all the way right into where those dopamine cells are and put them right exactly there for them to reconnect and everything? So I say all those things just to say that it's a very complicated process, and you will find people offering you stem cells through the nose, through the blood, through the spinal cord, and so far there's really nothing FDA approved at the moment. They'll charge you $5,000, and maybe it'll work, maybe it won't, maybe it'll cause you a serious issue. And so, kind of like going along with what Dr. Cardone said is, talk to us about it, ask us about it. If you have articles, you can send that to us and we can let you know about it. But most of the time, probably what we're going to say is, yeah, the FDA just really hasn't gotten there with anything yet, but we are hopeful, I think, across the board, whenever that may be.
I think the studies that they have done have been pretty small, and they've seen a pretty wide range, which is there's no benefit at all. There's some people that seem like they're better. Then there's some people actually that they have dyskinesias that now you suddenly can't control. So it's not that if we can find this perfect delivery system, it's going to work for everyone. It's very specific, and there's still a lot of things even within giving the stem cells. It's how do we adjust the response? And if this is a degenerative process that's going on, if I give you stem cells, maybe they're good for now, but is that going to go away? Are those cells also then going to get affected by this process that's happening? So the studies have been very small. The response is also variable. So I think the jury's out, and there's a lot more that needs to be done on stem cells.
I say it's not ready for prime time. I think a lot of, even the ones that are further along are either phase 1 or phase 2A, not even 2B. So let me go through real fast what the phases are. So there's the preclinical phase, and all the drugs that come to market have to go through these. Preclinical phase is petri dishes, animal models. Human trials are 1, 2, and 3. 1 is a small number of people and small number of locations, and is it a safe drug? That's that phase. And it's usually the active drug, and there's usually not placebo at phase 1. Phase 2 has a little bit more people involved, that are getting the medicine, and there are more locations. And that is, does it work phase? And sometimes it will break it down to phase 2A, and then it's phase 2B. So that's early, 2A would be like a 1, and 2B would be like a 3. And then 3 is more people, more locations, and the question that they use is, does it work better than what we have right now? Then, after all of that, and that's years and years and years, and so I've been with UPMC since 2008, and they were doing these stem cell trials way before I was even there, and we're not there yet, right? And we're 2009, right, because I'm very young. No, so it's just, it takes forever. They are being done in Europe. Yes, they are. Germany has a big site. Somewhere in Central America does. I have patients that want to go there. The problem is if you go and have stem cells in those places, then what if something happens to you? Because you're not going to, well, you can live there, but you know, if you come back home, what if something happens to you? Then you have to go back to these places. So, you know, it is something that we have to be careful with. They are using different types of stem cells now. They're using a lot of our own, so that's called mesenchymal. You know, but each person has a different set. So, you know, these trials are a little bit different when you're comparing person to person because it's not all the same drug that they're getting, right? Because it's, yeah. There was, I think, one patient out of all these studies also acquired leukemia. So I don't know if that was just they were always going to have leukemia, but there was one patient that had that after this. And he's right about how do we deliver it? Is it by an infusion? Is it, you know, we have to give the medicine through the spinal tap because that's where it needs to go. It's up into the brain, or do we deliver it by like a surgery into the brain?
Thank you, everyone, for your input. There's just a few more questions, and we're going to open it up. Do you feel that there should be a U.S. manufacturer of carbidopa-levodopa, especially with the recent loss of 2 suppliers?
We were talking about
Go
this
ahead.
earlier. I think we said
Oh,
yes, that would be great.
Sure.
Oh, yeah, this can be, yeah.
Yeah, more jobs here, and you know, guaranteeing that it's here, I think is all good.
More oversight,
But I,
more-
you know, I can't say that I know a lot about supply chain management and manufacturing and all those sorts of things. So it may be very easy for me to say yes and very difficult for it to actually be done.
Thank you. And Kaci, is there any real benefit to mushroom-infused coffee such as Rise?
Oh,
R-Y-Z-E.
I am not sure.
I'm giving you the hard ones. Is anyone familiar?
I always say, and mostly because I learned from this guy, and he always says that if it's based in part in some sort of theory, it's non-toxic, and it's not going to put you in the poorhouse. If you want to try it, by all means.
Sounds exactly like I would say it. I taught her well. I like the $20 idea.
$20
$20
Yeah,
is
yeah.
probably the right amount, but I mean, exactly. So there's always evidence, and everybody looks at supplements and over-the-counter things and teas and different Ayurvedic medicines, and it's going to be really hard to do studies on these things. Nobody's going to pay for the gold standard randomized controlled trials on any of these things because they're not going to make their money back. And yes, money still runs the world. And so you're not going to get the good trials. You're not going to get any of us to say, yes, I recommend this, right? We kind of reserve our recommendations for things that are FDA approved, things that there's gold standard trials for. That's how we come up with our recommendations. But there's not recommendations for everything. There's not gold standard trials for everything. And so those are my rules of thumb. You know, as long as there's some scientific rationale, and most of them have some sort of scientific rationale, but you have to be careful. As long as there's nothing toxic. And I haven't run into anything toxic that recently. Heavy metals you always have to worry about. It would be nice, again, coming back to American manufactured things, to know where it's coming from or what could be in it. And again, don't put yourself in the poorhouse taking things that aren't proven. That's just kind of my rules of thumb. And so if you come across these things or if you want to try them, as long as those things are okay, well, I don't care what you do. This is America. You're allowed to make your own decisions. And so at the end of the day, do what you want, but talk to us about it. And so if you are taking something like that, we still need to know about it because we need to know what else is it doing to you, what is it interacting with, what else could it be, and we want to make sure you're not doing something that we wouldn't recommend. But those are kind of the rules that I play by. I don't know what you guys do.
I always say to be careful of things that are marketed specifically to certain etiologies. You can kind of look at the ingredients. I always encourage because chances are you could probably find something cheaper that is not marketed specifically.
It's often B vitamins,
Yes.
mostly B vitamins.
I actually try to tell people to be really careful because anything that's marketed for like cognitive boosting, really if you look at it, it's just a bunch of caffeine. And that makes me worried. Like, are you cognitively impaired because you're so tired because you actually have sleep apnea or iron deficiency? And are you covering up something that otherwise should have been investigated and treated properly? So it's a caveat there.
And a lot of these things that are not FDA approved, you don't necessarily know exactly how much you're getting per dose. They'll give you an estimate, but that can vary wildly or be completely inaccurate. So in cases of, say, like Mucuna, which has like natural levodopa in it, who knows how much you're getting per dose? And for some people that's okay, but a lot of our folks, you really need consistent, regular doses in order to have the best benefit. And so that can potentially be an effect. And kind of going along with the poorhouse thought, just like there can be harm to you from a body perspective, a health perspective, there is financial harm possible too. Someone guarantees you that this probiotic, $90 a month, is going to cure your Parkinson's, and all it really does is maybe makes you a point better on our 110-point scale. And is that really worth it? That can be different for every person.
I actually had a patient show me a bottle that looked like this bottle of water, who they sold it to her and said that this is going to give you so much energy, and athletes drink it. And when I looked at the ingredients, it was salt water. That was it. So it was pretty much Gatorade without the flavor and the sugar. And she paid a lot for these bottles of water. And I know that sounds silly a little bit, but I mean, hindsight. So just, if you have something that you're interested in, you just show your doctor. Like I said, I tried to explain this was just salt water, but
Some of them can do harm also. If they have like B vitamins, too much B6 actually causes irreversible nerve damage, so I tell people that.
Okay, 2 more questions and we're going to open it up. What are your thoughts on the psychedelic and magic mushrooms, psilocybin, and how it could be a potential treatment tool for Parkinson's? Let's see. Who wants to take this question?
I was in
Dr.
Colorado, so
Oh, yeah,
just got legalized not too long ago. Obviously, more about medical marijuana, and one of the physicians that I kind of left right when I started, but Dr. Leahy did a lot in terms of medical marijuana, and more
his name
recently.
was Weed.
Dr. Leahy.
Oh, I said Dr. Weed. I'm like, that's fantastic.
That would be pretty funny. But so psilocybin was just made recreational in Colorado, and there's been some issues with that, recalls and toxins within it and that sort of thing. And so, again, a lot of it boils down to, is there data, are there trials behind it? And there really isn't yet, because for a long time, and still on a federal level, it is a very regulated drug that can only be used in very specific studies and examples and in small qualities and quantities and conditions. And so I don't think, and if someone else knows more, I don't think there's really been big research yet into psilocybin, magic mushrooms, what have you, as far as Parkinson's goes. Now, I know Johns Hopkins did a lot of research with psilocybin on therapy, like PTSD and more mood disorders, and seemed to show some positive benefit there. And so maybe from a mood perspective, that's, and I would say, an area of interest. I'm not going to say, positive, negative, et cetera, but it's something that we probably just need more time to study and do the studies and try to do it in a regulated fashion. Probably at this point, I would probably recommend against it, just because there's so little data behind it. What's the correct dose? The actual substances you're getting, if you're using a mushroom versus a concentrated version of psilocybin or something like that. So I think a little bit of a grain of salt with that one at this time.
Thank you. And the last question is more alternative as well. Jessica, I'm just curious if you have any thoughts on the vagus nerve stimulation. Do you have any experience? Transcutaneous, auricular, vagus nerve stimulation?
I do not, so I'm going to punt this to my colleagues.
Anyone have experience with vagus nerve stimulation
Not with using
and Parkinson's?
I had a patient who asked about it, so I did look it up, and there's just not a lot of data for it. It's being looked at for a whole lot of things. I was asked about it for autonomic insufficiency or deficiency, and the data that I read was kind of iffy. And so realistically, I don't think or know of any studies that are currently going on or available or really any data.
Yeah, so the vagus nerve stimulation, VNS, is being used in epilepsy. It's FDA approved for that. And what it is, it looks like DBS. You have a battery, it goes up into the neck and it attaches to the vagus nerve. The vagus nerve does some things, though, that's very important, like our swallowing and our speech and breathing and heart rate. So that can be affected with epilepsy patients. So they get hoarse, they might have problems with swallowing. They may have mild or like transient symptoms, but we do know that from that. Some of the things that they were looking, some of the small studies that they've done with the transauricular, so it's actually a stimulation by the ear. So it's external, not that internal battery. So you can, anytime you have anything external, right, you can get skin changes, but you know, it also might cause cardiac arrhythmias because it's the vagus nerve. You might have some hoarseness. You know, they're looking at, you know, what can it help for Parkinson's? And I guess the things that they're trying to see if it helps is motor, and then the other is walking. So we're not sure what the jury's still out on it. It's not FDA approved. So, and then we have some side effects. So the other thing they said that some of these patients had were verbal fluency problems. So that's kind of like a cognitive domain. So that may not be. So are all patients going to be candidates for this if it comes out? I'm guessing if you have a cardiac arrhythmia, probably not. It may not be good if you have memory problems. And so then they also are trying to figure out how often you have to do the stimulation. So these trials are very small and very short, and so it might be you have to stimulate for an hour, like so many days. And I don't think we know enough to say how this is going to be done, but they are looking at it for motor benefit and walking.
Thank you so much. And now let's open it up to questions. We have 2 microphones. Please raise your hand. We'll address your questions. Let's see. Any additional questions?
When am I getting my power back?
Yeah, that one. Let's see. Abby.
Tuesday.
Oh, Abby's coming to you.
How many of you recommend medical marijuana to your patients?
It depends.
Depends how you say recommend.
Pardon me?
Depends what you mean by recommend. So the question was, how many of you recommend medical marijuana for your patients? So I've been a certifier of medical marijuana since it got approved 7 years ago, 8 years ago, I forget how long it's been. And if you look at what medical marijuana is approved for in Pennsylvania, basically somebody opened a neurology textbook and went to neurodegenerative conditions. And I say recommend because there's no data behind it. There's very, very little actual good scientific research to support medical marijuana. And so when again, coming back to recommending things, I'm recommending things that have good, strong data behind them, and everything else is kind of, well, we can think about these things, not necessarily a hard recommendation. But my experience has been okay. I have had very little success with true motor symptoms of Parkinson's disease: tremor, stiffness, slowness of movement, balance problems. I have had secondary benefit from those things because the things I've found it to be a little bit beneficial for have been anxiety, pain, and sleep. And a lot of people in here know if they're anxious or if they're in a lot of pain or if they don't sleep very well, they shake more and all of their Parkinson's symptoms are worse. And so secondarily, I have been able to manage some or help some of those symptoms with the use of medical marijuana. But realistically, it's not something I typically recommend. It's often something a patient will bring up to me and then I'll say, well, let's talk about it. Unless really I've tried a lot of other things for those 3 specific areas and I haven't had a lot of success and I'm trying to figure out what else I can offer. But that's been my experience. But in terms of recommendation, and I'll let these guys talk for themselves, I don't know that I necessarily use the word recommend because it does not have that kind of data to support its use. That's just been my experience clinically.
Yeah, I like to say, here are the possible benefits, what we've heard, maybe some of it's anecdotal, maybe it's these small studies that we're doing, and then here are the potential risks. And kind of going along with the anxiety, it certainly can calm people down, and maybe you've seen that big video of the guy who has really severe dyskinesias and he's wiggling all over the place and he takes a couple hits and then suddenly he's like very calm. And so maybe that works for him. Maybe that wouldn't work for you. And THC, the psychoactive component, one of the psychoactive components in marijuana, can cause paranoia and anxiety. So there is the possibility that for you, it could actually make things worse. And then there's still a lot of questions about, is it THC? Is it, THA? And there's all these other compounds in marijuana. Or CBD. I think there's a lot more on CBD right now. And I think in Colorado, the big thing that we were using a lot of it for was sleep. So both THC and CBD, CBM, all these other things for sleep. And maybe there was some good benefit there. But at the end of the day, it was, this can affect your liver, this can make you anxious, this can raise your heart rate up, maybe affect your blood pressure. So grain of salt. I'm not going to say, yes, you absolutely should, but depending on your symptoms and how you feel and what your tolerance for possible side effects or risks are, it's something you can consider. And again, that financial risk. If someone offers you this joint that costs $100 is going to fix all your problems, you might want to be a little hesitating about that.
Yes, I noticed in the last 3 months, my legs became stiffer. Is there anything I can do to get them back to where they were, or do I have to live with this?
We know the first thing you should be doing. See, I love this group. They already know the answers.
Physical therapy. You need to go see a physical therapist. Oh, PU. I wish we had a magic wand. Everybody wants a magic pill or a magic thing, but unfortunately, you got to do the work. That's it.
I think also just talking with your doctor, because they may want to change medications. Are you stiffer before your next dose is due? Are you wearing off? Do you need to be tweaked a little bit with your medications? Is there a different medicine that might be better? I would speak with your doctor about that. All right.
You really should talk to your doctor.
He wants you to exercise.
He might have a plan for you, or she, or send a message.
I was involved with Rocksteady Boxing, but it has disappeared from the area. I don't know if anybody had. You guys all say exercise, but it's hard to find places.
You know you can exercise in your house, right?
Yeah, but Rocksteady Boxing is just.
I know. Everybody loved the Rocksteady Boxing.
Yeah. I just wonder if you guys know of anybody, or why don't you open up a gym with it?
So, Two Life Therapy and Wellness in the city has exercise classes almost every day for folks with Parkinson's.
Well, I live in Beaver County.
You live in Beaver County, okay. So, are my colleagues in Beaver County here?
So a couple of things. There are still a couple of classes going on, but a lot of people are saying there's some virtual classes. The foundation has some virtual classes. There's other classes. Agreed. We need more everything out there.
We just started one in Newcastle,
Kaci said she's working on it personally. That's what I heard.
North Hills still has it. A lot of my patients go around the North Hills.
Hampton.
Yeah.
Let the foundation know and let people in your area know, your local gyms, your local therapy groups. Let them know that you're interested. Maybe gather people and say, hey, look, you got a group right here. What can we do? And see if kind of a grassroots sort of effort can bring some stuff.
There are all sorts of instructors floating around, but they just need a place to go. So if there's a need for it, I'm sure that, Kaci can connect people that are instructors.
Some of the YMCAs have been pretty good if they're still around. A lot of them closed too.
Well, and the Rocksteady is tough because you also have to pay for it. So the certification to run a Rocksteady class actually costs a significant amount of money. It all comes down to a lot of things, but I think the more people like you, the more communication we have, the more chance we might have to open up more.
Yes, can you share any of your experience with the high-dose vitamin B1 thiamine therapy?
Yes. So I have a couple, so the foundation actually got a group of people together and they were all working on this, and a lot of them just happened to be my patients. And so at the end of the day, they have had a couple of people come back. The question was about high doses of B1, where there was a little bit of evidence coming out of a group of Italy. However, their lead researcher passed away from COVID. And so everything kind of came to a screeching halt. And so some patients in the Pittsburgh community took it upon themselves to try their protocols, use their protocols, try to see what would happen. I got mixed results, but I would say for the most part they were semi-positive. I had a couple of people come back and say that it did help them feel better. I had at least one guy come back and say I went too high, I had problems or just didn't feel right, so I had to cut it back down, and they're still trying to find the high dose correct amount. I don't think anybody told me that it was a cure or that it was magic. It's another tool that we have, or something that's at least worth looking into to see if it helps. Right? Anything that helps people feel a little bit better or helps them function a little bit better, or in my personal preference, exercise a little bit more, or be a little bit more active, I'm all for it. Again, the data is questionable in my opinion. That's just my opinion. I think there needs to be actually good trials done to prove these things or look further into these things, but I have had a couple of patients come back and say that they felt better, or they did notice a positive benefit.
I think we have time for 2 more questions.
I'm curious because I've been reading some articles on red light therapy being successful, and I don't know what your experience is with that.
So we had a study at Pitt a couple years ago looking at different lights. It was called SurePD. I think it was called SurePD. You had to sit in front of this television that was like this, and it was like you had to be so far away from it. You had a string that you had to bring to you. So far, nothing has happened with that data. I don't, so it didn't really move forward. So I don't know exactly if it was that beneficial, but they're looking at it. I know that. Did I feel like those patients that I had in that study did great? I don't know. I feel like it was kind of 50-50. So not ready for prime time.
But there are places that will sell it to you. So you have to be a little bit good. The data's not that good, at least from what I've read. But they will sell it to you as though it's a fix.
And it's more than
they'll sell it to you that you have to give it at least 6 months. So it is very important to be conscientious of these things.
Any last questions?
We're trying to save you money a little bit here. Talk with us.
That's right.
Go ahead. Oh, I'll take the microphone to you. We might have time for 2. But go ahead, Wallace.
Any comment about nightmares? Not hallucinations, but nightmares.
Make sure you're checked for iron deficiency, because the sleep stuff can get worse with that. Iron deficiency, and also sleep apnea or an actual sleep disorder such as periodic limb movement disorder. So I at least make sure patients have had a home sleep study and basic metabolic workup.
So there's also REM behavioral sleep disorder. They're usually not the most pleasant of dreams. So you're being attacked or you're defending something, and your body is half awake and half asleep. So you're dreaming and your body's flailing and punching out. That is something you need to talk with your doctor about, because sometimes we do things like melatonin or clonazepam if you're a candidate for it. That is something that you need to talk with your doctor. Or are you taking something right before you go to bed that might be causing a medication side effect? But it's very common. It is what we call a premotor symptom, so it can happen 10 to 20 years even before you start being slower or having tremors. And they can kind of sometimes just come and go. We'll talk with patients saying, did you ever do this? Because it actually sometimes helps with the diagnosis for us. And they'll say, oh yeah, I did that in the past, but I don't do that anymore. Like I said, they may come back, but it's not like you have like this subconscious thing that I'm going to hurt my spouse, but it's just that sometimes they're near you and you're kicking, punching, and screaming, I usually tell the spouses, you may not want to try to wake them up because then you can get taken. I've had patients throw their spouses onto the ground. You know, you may want to just turn the light on and start making noises to slowly get them out of that dream state more than, you know, hey, are you okay? They're okay. A lot of times patients don't even remember what they dreamt about after they're kicking and talking and screaming. Some do, and I usually hear it's I'm getting attacked or I'm defending something.
And then, you know, the nightmare side of things too, one thing that I think is important for us to know about or for us to ask about as providers is, you know, are they related to past events? You know, can there be some like post-traumatic stress component to it? Because there potentially are separate ways to treat that. And I do hear this from time to time with some of the medications we use. So the levodopa, some of my patients will say, I started this and I'm starting to have more vivid dreams or nightmares or something. And okay, can we then maybe adjust your dose? Do we say less at bedtime or move it earlier in the day? And that's another caveat. A lot of people, or pet peeve is a lot of people start there, or someone tells them to take their Cinemet 3 times a day and they take that dose at bedtime and it's out of your system by the time you wake up. Can we move that during the day, help you move better during the day and help your dreaming at night? So yeah, just let us know like trends, and if you start a new medications, do you think it's related to the carbidopa, levodopa, and see if we can make some adjustments based on that.
Another person who should send a message to
Yes,
their
okay,
doctor.
the last question of the day. John, here, I better go to you.
For some time now, I've had, not quite sure how to describe it, patterns. If I look at a blank surface, it may look like swirling eddies or grids. I looked the other day at a line of prose and it looked like a musical staff. Have any of you encountered this kind of thing is it a Parkinson's thing, and does it tell me anything?
Well, to some degree, it sounds like it could potentially be what we call illusions. So something that is there that is then misinterpreted. You know, you see a lampshade and you think it's a cat, or a coat off in the distance looks like, you know, it's something else. Or, you know, patterns can start to become moving or swirling. And I think one also important thing to look at in terms of that is also, is there an eye thing going on too? You know, right, and then, you know, just kind of for everyone, that's, I think, an important thing to make sure that that's not playing a role. But it could very well be related to the Parkinson's itself, causing illusions and potentially sometimes the next step. Not that this may happen, but kind of exists in that realm of maybe hallucinations where something that is truly not there you see, as opposed to misinterpreting a thing that is there or something that is there changing. So it could be related. We want to rule some other things out. And again, another good question to make sure you're talking with your doc about and seeing, you know, adjusting meds, other medication options, what we can potentially do to help with that.
Yeah, sometimes it is medications. I can tell from a personal experience. I had what looked like an LSD trip. It wasn't an LSD trip, but I just took a medication and I saw this rainbow effect that was like as someone walked by, they had a trail, and it was just the medication. I stopped it and I tapered it off, and then it went away. So, you know, sometimes the brain and the eyes, there's like just sometimes there's a misperception. And, you know, do you have an infection? I mean, there's lots of things. Is this coming on suddenly? Is this something that's been creeping up? Is this kind of like a precursor to having other visual stuff too? Is it because it's darker out because you don't have power and your mind is playing tricks on you? Yeah.
I also have a low threshold for sending patients to formal cognitive testing because some of these little things that patients notice is really part of a bigger picture that is uncovered through formal cognitive testing. And if we have a specific diagnosis there, it can help us guide medication management.
Thank you. Any last thoughts, medical expert panel, healthcare professionals? Thank you so much.
Thanks for having us.
We're going to wrap it up. Let's see. We have a few words on the screen. Just so you all know, we are a local nonprofit. So what we do is stays locally, and all of our dollars raised do as well. And if you don't mind, I'll let you kind of just look that over. We're here for you. And if you don't mind completing your survey, even if it's just one per couple and just place it on the, keep it on the table, we'll collect those. Because we're kind of looking at, there's an expense to this conference. Are there other ways that we could have it without maybe charging? But either way, we'd love to get your input. I'd like to thank all of our sponsors, especially Amneal and Supernus, vendors, volunteers, presenters, Hilton Garden Inn, AV, and if I missed anyone, all of you. So thank you for coming, and we hope to see you at Step Forward last Saturday in September or before that. Hope, joy, and remember, hope, joy, and liberating. Thank you, everyone, for coming.